Okay, good. Testing 1, 2, 1, 2. Thank you. Mic testing 1, 2, 3, 1, 2, 3. Mic testing 1, 2, 3, 1, 2, 3. Thank you. Good afternoon, everyone. Welcome to the Zero Dose Learning Hub Nigeria webinar series. This is our first edition. Thank you for joining in time. We are waiting for the rest of our participants to join in. Once we have a suitable number, start. Thank you. Good afternoon, ladies and gentlemen. On behalf of the Gavi-led African Field Epidemiology Network, AFINET, and the Africa Health Budget Network Consortium, I extend a warm welcome to each one of you to this maiden edition of the Zero Dose Learning Hub Nigeria webinar series. I am Margaret Wisdom, and I have the honor of being your moderator for today's session. So today we are gathered here virtually to delve into an important dialogue centered around innovative strategies for identifying and reaching zero-dose children in security-compromised areas. This webinar serves as a crucial platform for sharing insights, experiences, and best practices that can pave the way for impactful immunization efforts. Your participation in this critical discussion on immunization strategies is invaluable, and we're excited to have such esteemed speakers and participants with us. Throughout our session today, we encourage active participation and engagement from all participants. Your insights and questions are vital to enriching our discussions. So without further ado, let's kick off the first session of the AFINET AHPN Zero Dose Learning Hub Nigeria webinar series with our esteemed speakers. Up next is Dr. Patrick Nguku, the Regional Coordinator for Anglophone West Africa at AFINET. Dr. Nguku, the floor is yours for the opening remark.
Thank you, Margaret, and welcome everybody. I'm sorry I will not put my camera on. I have challenges with my internet bandwidth, so allow me just to read my opening remarks and really to say, I see we have close to 128 participants. So good afternoon, everyone, and welcome to this series of webinars. Just to say that the Zero Dose Learning Hub is a global Gavi initiative running in 4 different countries, including Uganda, Mali, Bangladesh, and Nigeria. In Nigeria, this is the Learning Hub is a consortium between AFINET and African Health Budget Network. And over the last 12 months, we've been implementing in Nigeria. We formally launched in September, and we're happy to see that some of the participants actually participated in the launch. So I welcome you all to this webinar. We are privileged to have esteemed speakers, Dr. David Nshe, a program manager and technical lead of CHAN, as well as Dr. Musa Melton, an AFINET State Field Coordinator in Borno State. They will be delving into crucial topics surrounding immunization strategies in not just the country, but particularly in conflict and insecure regions, sharing some of their insights and experiences. As you all know, these are areas that have contributed significantly to under-immunization and missed communities, as well as zero doses. We are really encouraged by the participations we have had so far with regards to engagement with engagement, and I encourage you all to actively engage with our speakers and participate in the discussions to gain valuable knowledge and insights that can contribute to our collective efforts in reaching zero-dose children and improving immunization coverage in these challenging settings. I particularly want to recognize our colleague, Dr. Heidi from Gavi, as well as other colleagues internationally. So thank you very much, and over to you, Margaret.
Thank you, Dr. Nguku. We also have with us today Dr. Heidi Reynolds. She is a Senior Specialist Evaluation and Learning at Gavi, the Vaccine Alliance. She will be sharing with us a brief on Gavi's zero-dose learning hubs. Dr. Reynolds, you have the floor for your presentation.
Thank you, Margaret, and thank you, Dr. Patrick, for those words of introduction. It's a real pleasure to be here with you today. I'm going to share my screen. I have a few slides, so please let me know at any time. I'm gonna stop. If you can stop sharing, I'll bring up my screen, my slides here. Okay, so you should be able to see my slides now. And I'll put it on full screen. Great. Yeah, thank you very much. And it's a real pleasure to be here with you all today. And welcome to the first Zero Dose webinar series, which is focusing on locating and reaching zero dose children in conflict and volatile areas, with a focus on Borno State. And thank you so much, Dr. Muknon and Dr. Melton, for being willing to present today. I'm really looking forward to this sharing event because, as you may have realized now, this is not just related to what the Learning Hub scopes of work are doing, but also, what our partners are doing in working in this area. And it is really a critical sort of aspect of the Learning Hubs is to bring together the learning that's happening across the country and across partners. But I do want to start by setting the stage with the Gavi Learning Hub activity and project. To sort of help you understand why we're doing this and what we hope to get out of it. As you know, the 5.0 strategic period for Gavi started in 2020. And it was a critical period where the focus shifted to zero-dose children. So Gavi, which Gavi defines as children who've never had DPT1, but that really is just meant to be an indicator and a marker for children who have been missed by immunization altogether, and their families, and the communities where they live. And at the beginning of the strategic period, the Alliance acknowledged that we do not have all the answers to the questions about how to reach these communities who've been systematically missed and how to bring them into the health system. And so the Learning Hub is an approach designed to support that learning. And in December 2020, the Gavi board supported the establishment of a set of learning priorities, which I'll show you in the next slide, around which this monitoring, evaluation, and learning are coordinated, including the Learning Hubs. The learning priorities are a set of questions that are relatively high level, and they're aligned with the IRMA framework. IRMA is identify, reach, monitor, measure, and advocate. And it is meant to help partners globally align behind answering a set of questions that were deemed key to understanding progress against the 5.0 strategy. And as you can see, we have these questions aligned in each area, although there are some cross-cutting areas, such as better understanding the cost of reaching zero-dose kids and how to have those programs be more sustainable. One thing that I would like to point out that's very important in the Nigeria context is that in December, AFINET with partners supported a learning agenda workshop to identify what were the priority questions for Nigeria, as well as understanding how they're going to be answered and how the partners are going to help answer them. So, and it aligns under this larger framework and is meant to be sort of a quote unquote North Star against which partners can align and communicate their work. And I think you'll see that starting to come together in this and how we do that in this webinar, where we're looking across partners' work and learning from that. Back to sort of a broader view of what the learning hubs are meant to do. As Dr. Patrick mentioned, the learning hubs take place in 4 countries. In addition to Nigeria, we're working in Mali, Uganda, and Bangladesh. And the objectives are to synthesize learning of the barriers to reach zero-dose children and use that to help understand how to better do program planning and tailoring approaches to reach them. And then there is a set of activities related to understanding what approaches are effective to reaching them. And then we want to continually improve the metrics, measures, and methods to understand where they are and how to reach them. The learning hubs are at the country level, a national level learning system to document the effects and program shifts of targeting at the subnational level where those zero-dose children are located. So it is an approach that is helping Gavi understand what's happening at those targeted subnational areas where the children live and how programs are pivoting to reach them. In terms of selection, we selected the 4 countries in order because they had relatively high numbers and proportions of zero-dose children, but we also wanted to ensure that we had geographic variation by region and that they were also receiving funding that was targeted to those subnational levels. And an important feature of the learning hubs is regular dissemination and feedback of learning. Key users of the information are obviously the Ministries of Health and EPI programs, but as well as other country partners and Gavi and Alliance partners. So the learning hubs have, across all countries, have similar scopes of work, but in each country, there's very unique aspects that are happening, which is meant to, be responsive to what are the national priorities in the zero-dose space. So all countries are working on stakeholder mapping and engagement. And in this case, AFINET has a partner AHBN that's really supporting in this area. And then they just finished a rapid assessment of the situation in 4 states, Kano, Sokoto, Bauchi, and Borno. And those informations are will be available and disseminated ongoing. And then we're working to improve timely monitoring in those subnational areas, and then conducting implementation research to understand the effectiveness of approaches. And throughout the project, knowledge translation is important. That means taking those findings and having them communicated in a way that really facilitates uptake in terms of integrating into policies and programs. And then throughout, we're working to monitor about what's working to how the project is working through implementation. I do want to mention that the four states, as well as the targeted LGAs where the learning hubs are working, are part of the priority 100 LGAs that were defined under the National sort of Emergency Routine Immunization Coordinating Center, NARIC, and it is meant to generate evidence in those areas. I do want to acknowledge before I turn it back over, at the global level, we do have a partner, JSI, with the Geneva Learning Foundation and the Indian Institute for Health Management Research as our global learning partner, who had the objectives to support implementation of the country learning hubs and then at the global level to produce and share evidence across countries and partners. There is a website with a lot of material. It's zdlh.gavi.org. And in particular, I wanted to highlight that some of you may have participated in a virtual experience sharing event that the Geneva Learning Foundation led. And so there's a lot of interesting information that came out of that specific to Nigeria about what practitioners are doing to identify and reach zero-dose children in those settings. So as I mentioned, part of the mandate of the Learning Hub is to also bring together evidence and sharing, and I'm really looking forward to this webinar today so that we can hear more from our partners working in this area, Dr. Muknan with Chan and the Raise for Health Project, and Dr. Melton, who can share more experiences about AFNet work. And so I also want to make sure that we have a really interactive session today. So please think through about what are you learning from our colleagues today, and what's new, what do you want to know more about, and what can be taken up and used in your work, and then what do you want to know more about moving forward. And hopefully you can use the chat and the Q&A, and as well as during sort of come on live and be able to ask and share your questions. And so with that, I will end and turn it over back to Margaret. Thank you.
Thank you, Dr. Reynolds, for sharing such a comprehensive overview of the challenges and opportunities in reaching zero children. It is indeed critical to generate and synthesize our learnings to influence program planning and tailor approaches effectively. So for those of you that are just joining us at this first session of the Zero Dose Learning Hub Nigeria webinar series, we are happy to have you here, and we look forward to robust and fruitful discussions. So I'd like you to sit back, amp up the volume of your devices, keep your questions and contributions ready as we welcome the first speaker of the day in the person of Dr. Muknan David Nshe. He's the Program Manager and Technical Lead for Christian Health Association of Nigeria, Africa Christian Health Association's platform. He works with the Raise for Sahel project, and he will be enlightening us on the first topic for today, which is strategies for identifying and reaching zero-dose children in conflict zones. Dr. Muknan, you're welcome. Please share your slides and start when you're ready. You have exactly 20 minutes to make your presentation. Thank you.
All right, thank you very much. Good afternoon, everyone. Good morning, good evening from wherever you are joining us in the world. I just want to confirm if you can hear me loud and clear.
Yes, sir, we can hear you.
All right, thank you very much. And I want to use this opportunity to appreciate Gavi and the Zero Dose Learning Hub for this opportunity to share the experience of the Raise for Sahel program implementation in Nigeria. I will be sharing our experience as we implement the program on the topic strategies for identifying and reaching zero-dose children in conflict zones in Nigeria, or as we all call it, humanitarian settings. I'll be using this outline to make my presentation. I'll give you a general overview of the program, the principles for identification and reaching, the landscape geography, and then the tailored strategies we have used for the implementation, and of course the challenges, recommendation, and then I will conclude. As a way of introduction, the Raise for Sahel program is an acronym for Reaching and Adapting Immunization Services Effectively in the Sahel region. And this is a multi-country, multi-partner zero-dose immunization program funded by Gavi, the Vaccine Alliance. And of course, it's implemented in Mali, Burkina Faso, Cameroon, Chad, Central African Republic, and Nigeria. The objective is full immunization of zero-dose and under-immunized children in humanitarian settings under the leadership of World Vision in partnership with Food for the Hungry Core Group, ACHAP, DIMAGI, and Nigeria. Chan is implementing this particular intervention. As just a way of introduction, who are these zero-dose children? I'm just going to write on what Heidi defined to say that the zero-dose children are children who have not received routine vaccination, and the proxy for measuring this is those that have not received the DPT1 or Penta1 vaccine. And for the zero-dose implementation program, immunization program, we are very interested in the children 12 and above months that have not received any form of penta vaccine, because these are the ones that the health system is not routinely reaching. Who are the zero-dose communities? These are communities with a high proportion of the zero-dose children, and they share similar social and socioeconomic and geographic attributes. Of course, we are here discussing those affected by humanitarian challenges, fragile and conflict settings. And the under-vaccinated children are children that have not received complete dosage of the third dose of the pentavalent vaccine. So those become a very important cohort for implementation. Now, in Nigeria, I just want to run you through how we came about our implementation, selection, and how we are going about the implementation of this activity. And so for Nigeria, we all know that Nigeria has a very high burden of zero-dose children. Over 2 million children are zero-dose children. But as a national strategy, the Nigerian strategy for immunization and PSC strengthening has selected 100 priority LGAs in 18 states with the highest burden of the zero-dose children. It is within which the Race for Sahel program is implementing in Sokoto, Borno, Kaduna, and Plateau State. And we're implementing in select communities and wards which fall under the description of the humanitarian crisis. Of course, this our implementation started with the inception phase in July of 2022 to December. And then we started implementation and programming with receiving a letter of approval and other formalities and setup of teams in country in the different geographies, and then started implementation and vaccination of children sometimes in August of 2023. In terms of the description of the different landscape where we are working in Borno State in 5 local governments, in Kaduna 5, Plateau 4 local governments, and Sokoto 5 local governments. But in this phase of implementation, we began implementation in 2 of each and then 1 extra in Sokoto. And I'll explain why, because of ease of access and the kind of insecurity that has been seen as we underwent the desk review and interacted with the different communities. You would see them in Borno State, armed conflict, majorly Boko Haram, criminal elements, kidnapping, banditry, cult activities in those local governments. In Kaduna, armed conflict, of course, the Boko Haram took into those places, criminal elements. And for Plateau State, we see a case of communal and ethno-religious crisis and violence affecting the communities where we're implementing. But Sokoto State is mostly an interplay of criminal elements, kidnapping, cult activities, and other forms of criminalities. Now, when we are looking at humanitarian principles for identifying and vaccination, this is probably one of the most important slides that define the strategies and tailored approaches we have used for identification and reaching the different communities. Key in identifying and reaching is the fact that unlike in stable settings where you have the luxury of first identifying, enumerating, doing micro-planning and other forms of activities for routine immunization, in fragile and conflict settings or humanitarian settings, sometimes the identification and reach have to happen concurrently. And in such a case, we have deployed strategies to first identify, but then also concurrently update the information we have as we reach the communities that we are vaccinating. Key also is the fact that the humanitarian principles of humanity, impartiality, and neutrality undercovers is the bedrock of all the activities we implement. Humanity, we are saying that every child or every human being that we meet that needs the intervention in terms of routine immunization is reached no matter where he or she is found. In impartiality, we are saying that the actions are carried out despite the different places where the children are found. And this, for us, they are humanitarian principles that, overlay what we do in terms of our intervention. And in neutrality, we know that for fragile and conflict settings, sometimes we are having to interact with non-state actors and other entities or other population groups that are not necessarily in line with government interventions. And our strategies are targeted at reaching those kind of communities. Key also as a principle is engaging community stakeholders, which includes existing community platforms and creating a relationship with local power brokers and gatekeepers, as we call them, religious and traditional rulers. This we've continued to do because we have discovered that apart from the fact that social-cultural issues affect access and uptake of vaccination, access to those communities can only be negotiated properly with these power brokers and stakeholders. A key principle we have used in identifying and reaching these communities are continuous access negotiation using robust community engagement and intelligence. And with this, we're engaging with the stakeholders, like I mentioned earlier, and we go to those communities, discussing with them to negotiate for access. And this is done by the field teams who have a robust understanding of the socio-cultural dynamics of those communities, who are the levers and who are the people that would grant access to those communities and enable access to vaccinations. A key principle that we have leveraged on to use is the integration with other humanitarian programs in terms of service delivery approaches and also security intel. And here we are bundling services, not just the routine immunization services, but also nutrition services that the zero-dose child also needs. Of course, the zero-dose child is a child that has multiple deprivation, and for you to adequately reach them and receive access in the way that is required, it is important to also integrate with livelihood nutrition services that they would need. Partnership with local humanitarian actors has become a very important strategy and principle that we have used using different organizations in the grassroots that have established networks and enjoy the social trust of those communities. So we are not coming to just establish systems that are foreign to them, but also use these local organizations like the Asatahil Foundation in Sokoto State, where we've worked, the Archie Community Chigari Foundation. These are partners that have understanding of the robust community networks, and then we leverage their networks to also implement these services within the communities. Immunization in humanitarian settings work with adaptive programming and scenario planning. So sometimes you have to change the strategies for implementation because it has become necessary. And this happens because insecurity is a very fluid system. And so for you to be able to reach these communities that are either under the siege of Boko Haram or internally displaced persons or people that are mobile population in all of the different states where we work, we have to adaptively plan your scenarios in a way that you would access these communities. And of course, unlike the campaigns where it's a one-time approach to going to vaccinate these children, full vaccination is the key bedrock for our implementation, because we need to ensure that we enjoy the social trust, because we need to go back to those communities often to make sure we achieve full vaccination. So these guiding principles are what we use to identify and reach these communities. So what did we do as we began implementation? How did we tailor our strategies, coming to practical strategies that the Race for Sahel implementation deployed to achieve the successes that I will share in the slides that I'm presenting? The first thing is that we have to use data to decide where and what we are going to be doing. And so we began with an administrative review of the current information we have in terms of the different communities. Like I said, we work within the 100 prioritized LGAs in Nigeria in this state. And then as we did the depth review, interacted with other partners, we're able to identify the communities that are not reached fully within the humanitarian settings. And as we went about that, we conducted a quick informal assessment where we did the mapping of communities. And the pictures by the side, you would see how we conducted this informal assessment, where we sat down with community stakeholders, including women, youth groups, and men, and even security apparatus, to discuss and to get the numbers, the places, and the distribution of these communities that are not able to be reached by the current or conventional health system approaches because of the fragility and the humanitarian situation where they are found. As we did that, we mapped out those communities using the geographic information system on the map so that we can tailor our strategies and monitor our approach. As we continue to do that, we conducted enumeration during the reach approaches to update the target population. So we understand that micro-planning is a reiterative process. So beyond just micro-planning at the outset or at the beginning of implementation, as we reach new population groups, we're continuing to update our information to make sure that these new populations that we are finding out, we can plan for them and deploy tailored strategies to meet them. We also engage linkages with local and indigenous communities who have a very good understanding of these communities. They are able to provide intel to the Race for Sahel community, Race for Sahel service delivery teams. And then we also leverage on the social trust that we have with the different communities in terms of deploying strategies. That has helped us to identify communities and to leverage strategies that are tailored for that. One of the key things that has helped us is the mapping of these communities, because some of those communities are highly mobile, and then they are not within the current radar in terms of strategies for implementation. So we developed precise GIS maps for targeted regions, pinpointing missing zip communities in those communities that we're implementing. And on the right, you would see the kind of maps that we generated. And then as we continue to implement, we're able to demonstrate the places that our mobile teams are deploying strategies to. And as we sit down to adaptively plan for subsequent sessions, for the different population groups that are missing, we're able to make data, use data to decide on why and how to reach those communities. As we did that, we continued to establish monitoring systems for adaptive planning and use of optimized resource, helped us to we optimize our resources in allocating teams to such communities. So what we did is that when we realized that certain communities may have moved because they have been displaced by different kinds of insecurities, we are able to reprogram our teams to the wards and places that their existing teams need to reach the communities. As we did that, we are able to classify our communities into those that are mobile populations, that is cattle herders, nomads, miners, migrant farmers. These kinds of population, we're able to reach them with the mobile settings, and outreaches are taken to their various communities, and many times they are house-to-house vaccinations, from compound to compound, and we use a migration tracking system using the geographic information system to track them. Another strategy that has helped us is to also look at the other needs of those communities using the One Health approach, leveraging other needs in terms of the needs for their cattle, and to bundle the humanitarian health system cluster nexus in terms of implementation. For the communities that are under the categorization of forced migration, we have communities that are either in IDP camps or IDPs, internally displaced persons within host communities. We also deploy mobile strategies to identify them and to, vaccinate children within them. And as we do that, we bundle our services with the water, sanitation and hygiene services, nutrition and shelter, and that we have been able to achieve with the collaboration with some of our partners. Then we have communities that are, sharing borders with Cameroon in terms of Borno State, and in Sokoto with Niger Republic. What the teams have tried to do is to monitor the movement so that they can be linked with border vaccination team and make sure that we achieve full vaccination. For communities that are in active conflict or chronic exacerbation of conflict, the strategies we have deployed is the hit and run strategy, where the teams look for window of opportunities to go into those communities with the security intelligence and intel we receive from the community structure that we chiefly depend on to be able to vaccinate those children in those places. Now, as we did that, we have been able to provide and vaccinate over 250,000 antigens in those communities. 42,000 children have been vaccinated with life-saving vaccines. Of this number, 25,000, which is about half of the number, 50% of the number, were able to receive Penta-1 vaccination in those communities. And these are the distribution of the different antigens per our KPIs for the ZIP intervention in the different states that we have been implementing. Other parameters that we have succeeded and we measure in terms of our successes as we continue to vaccinate is the quick informal assessment, where it helped us to unpack the different sociocultural challenges that will help us to tailor, contextualize our strategies to these communities, which included a gender analysis that we did to help us deploy teams and strategies in a fashion that would be acceptable to those communities and will be accepted by them. And we've been able to recruit team members who have high risk appetite, who have a good understanding of the sociocultural dynamics, who are able to go to those communities easily at the different times that we need them to go, using their daily implementation plans. And we have been able to set up teams that include both the data recorders and also community mobilizers that go into those communities and mobilize and also get those children vaccinated. As we deploy tailored strategies, we've been able to deploy social and behavioral change communication strategies by talking with women in the different groups and communities, leveraging on the existing systems and community strategies to train, train health workers and community members that have a high understanding and respect of the community to go into those communities and, discuss around the defaulter and help us to do defaulter tracking. We've been able to conduct micro planning and develop micro plans, that help to plan the different strategies. We'll be able to also deploy tailored strategies in terms of the GIS system, use live longitudinal monitoring using our tablets to monitor our program and implementation. As we did that, we recognized that as government deploy campaign strategies into those communities, we happen to be a good system that reaches these communities where the conventional system are not able to do that. And we've been able to support the government to, vaccinate and introduce different antigens that the NOPV campaigns that have been conducted in various states we have supported. One key strategy that has helped us in achieving our results is the sustained intensification of the routine immunization, where our teams go on to vaccinate continuously using their daily implementation plans across the different communities. For want of time, we also enjoy the partnership of different government institutions at different levels, where we engage with the government to make sure that they understand our strategies and they know that we are here to extend their coverages into the different communities. This also just shows you the support we provided in terms of the campaign. The challenges we face as around the occasional stockout of vaccines, vaccine policy, high cost of living, and political transitions. In conclusion, I would like to say that full vaccination of 0 dose and under-immunized children in humanitarian setting is a cornerstone for achieving global health security, and partnership is key, with local partners that understand the context, and service integration becomes a low-hanging fruit that we can leverage. As we continue to provide services, we leverage on community platforms to increase our access, and we use humanitarian principles to deploy strategies to these communities. I'll be very happy to hear your thinking around the things we have deployed and our contributions on how we can improve our strategies. Once more, I want to celebrate our heroes and heroines in these communities who are the field staff that continuously risk their life to provide services in these communities. Thank you very much for listening, and over.
Thank you very much, Dr. Nche. We also celebrate all the heroes and heroines. They are here with us, joining live on this webinar. Thank you once again. Before we proceed to our next segment, I encourage all participants to take a moment to type up their questions in the Q&A box, the comments section. Your input is invaluable, and we'll address as many questions as possible. Please note that we also need you to share your experiences, your live experiences, your field experiences, success strategies, challenges, opportunities, etc., of what you have experienced on the field. Up next, we have another expert in the immunization space in the person of Dr. Melton Musa from AFINET, Nigeria. He's a senior field epidemiologist and the state field coordinator for AFINET from Borno State. He will be taking us on the second topic for today, which is immunization in insecure areas. What has worked in Borno State, Nigeria? Dr. Melton, you are welcome. You have 20 minutes for your presentation. Thank you.
Thank you so much, Margaret. Good afternoon, everyone, and good morning, wherever you'll be joining us from. I'll be sharing some of our experiences from vaccination in Borno State over a period of between 2016 to date. My presentation will cover non-traditional service delivery strategies and unconventional methods we have used to deliver services in the conflict settings of Borno State. This is my outline. I will be presenting some contextual background to the conflict, challenges of immunization in conflict settings, the approaches for delivering vaccines, polio vaccines, non-polio vaccines, and other services, some of the best practices and the lessons we have learned, and then we will reach a conclusion. I want to point out that Borno State is on the border shares a border with Niger, Chad Republic, and Cameroon. This plays a role in the conflict that the state was dealing with. And we also have other national borders with Yobe, Gombe, and Adamawa State, where also this insecurity has been affected. So again, in 2010, Boko Haram started an insurgency that the mode of operation was killings, use of bombs in gatherings, and even attacks on roads. And WHO declared a humanitarian emergency and then an emergency on polio. At the peak of the insurgency, almost all the local governments, which are the districts in the states, were affected. And since then, there has been military action by the government of Nigeria, and this continues up till today. The map on the left, just to indicate the number of incidences that we used to register, even though now it's less, but then everybody knows where to go and where not to go, because these incidences still happen across the state. Now, this is just to show us pictures from the field. There's this picture with Bedford. It's a picture of a vehicle-borne IED that was exploded on a road during a campaign, a polio campaign. And if you see up here, you will see where ice packs that are used for vaccination were burned and destroyed by insurgents. So the immunization system gets affected immediately in conflict setting because infrastructure and structures are destroyed. Now, what are the challenges of immunization in conflict settings? Number one is the destruction of healthcare facilities and even the supporting structures. The vaccine cold chain management equipment are destroyed, health workers are displaced, and even communities are displaced. So you'll see massive displacement of population in Borno State during this situation. So there are also issues of psychological trauma, poor living conditions, because people will have to congregate and move towards safe areas from areas that are not safe. So you will see large number of traumatized women and children who are always just looking for what to eat and where to stay, and not really immunization. The next challenge you will see is that there are populations that are trapped within conflict areas that cannot move out. And that's one of the big challenges that we were confronted with in Borno State. The other thing that I want to highlight is the issue of outbreaks of vaccine-preventable diseases. One of the key outbreaks that we witnessed in 2016 was when Nigeria had gone 2 years without an outbreak, without a reported case of polio, wild polio virus. But in 2016, while we were hoping that we would soon get certified, suddenly we had these 4 cases of wild polio viruses coming from insecure areas, indicating that vaccines have not been reaching those locations. And that was a major, major turnaround to vaccination in Borno State. Now, acute malnutrition issues, very important. It forms one of the challenges that you'll be confronted with in a conflict setting. Then, of course, the destruction of communication network. There are other non-conflict related challenges which I will not emphasize or emphasize them, but you can look at them once the slides are shared. Now, these cases, this is a slide showing the wild poliovirus cases that were reported from Borno State in 2016 after going 2 years without any outbreak. These cases were coming all from security compromised locations. One of the cases which was reported in Jere came from a child who moved from Marte to Jere as an internet displaced person. And the stool sample was taken in Jere, and the child turned out to be a positive wild poliovirus case, which indicates that the virus was circulating in those locations and vaccines were not reaching those places. So in conflict settings, there are certain locations where vaccines are not being provided. Now, I also brought this slide up to just let you know that during conflicts, you will almost continuously have outbreaks of measles and other vaccine preventable diseases. This is EpiCov showing reported cases of measles between 2021 to 2024. Currently, these cases are being reported. Sometimes these cases are from the children who have been trapped for many years without getting any vaccination. So what did we do and what was our response? The first and the most important response in conflict setting is engaging the actors in the conflict. And one of the things that we did was advocacy to the military from the highest level, from the Chief of Army Staff, from the Ministry of Defense. That gave an opening for the immunization programs to be able to navigate the conflict setting, at least without any challenge from the military that were engaged in the conflict. And then one of the other things that was very important in this is that the military understood the importance of immunization and polio eradication as a responsibility that they needed to support. And so we got commitment to support us wherever we needed to go. This is very key in conflict settings, and we need to pay attention to this. One of the things that we did also was the continuous security threat accessibility mapping, very critical, very important. The whole state, the map you are seeing is the world level map for the states. What we did was to categorize all the wards based on accessibility. And this is based also on the security threat. So we had accessible wards where health workers could deliver services freely without any challenge. We had the partially accessible wards where some level of local vigilante could support the teams to deliver services. However, we had these red areas where we couldn't go. And what did we need to do? We needed to do something because these are the places where children were trapped. These are the places where the wild poliovirus was circulating. Now, we went ahead also to classify these wards based on service delivery for routine immunization. And so we had wards that these services were going on normal, and we had wards that were accessible and services were interrupted. We had these partially accessible wards where services were provided. And then we had these partially accessible wards where there was no services being delivered. And then we had these wards also where full services were being delivered. So this helped us in planning and designing strategies specifically for each of these areas. One of the biggest strategies we used for delivering services was the reaching every settlement. After classifying the states based on the security accessibility and the threats, we now were able to focus on settlements that had at least some moderate level of low security threat. And we designed strategies to reach these places with vaccines, both polio vaccines, measles vaccine, and in most of the times, we ensure that we take routine services alongside. So the strategy is to use local vigilante to deliver services. With their support, we're able to go to many settlements. Now, reaching inaccessible children. At a point, we were confronted with the question, what is the total number of children that are unreached in these security compromised areas or places where we've not been able to go? Will they be able to sustain the circulation of wild poliovirus? One of the things that we needed to do is to make sure that we estimate the number of children in those locations and be able to come up with a strategy. So the reaching inaccessible children with vaccination and surveillance activities, looking for wild polioviruses from children that are show paralysis. This was done in coordination with the military. Where the military conducted operations, they also, alongside their medical corps and their staff, helped to conduct other additional services for the immunization. This strategy is the community informant in inaccessible, one of the strategy that works very well. It aims to reach highly insecure settlements using locals. What that means is that in every conflict setting, you will surely find someone who will be able to go to those locations. And that was an experience that at the end of the day helped us to be able to take vaccines. You can see from the picture a person on a horse. He arrived at the settlement and he was able to vaccinate. So this person had some level of healthcare ability and was able to deliver services. So one of the things we did to be able to estimate the number of children unreached in those settlements where we couldn't go and no one could go was the use of satellite imagery to estimate the unreached population. What that means is, what is the population in the red areas? How many of these children are under 5 years of age? And then what can we do to be able to reach them? So what the satellite imagery helps us to do is it will indicate and detect for us abandoned settlements. So we did not have to spend time planning for those settlements. However, it also helps us to show population movement. Between 2014 and 2016, this Marte local government, many of the population moved because of the insurgency, and they were able to, the satellite imagery was able to show us that information. So what did the satellite imagery help us to do? Mapping where people were found. We're able to say, these are the locations where people are, these are the locations where they have been abandoned. This is what, again, it helps us to do. So we're able to see where settlements have been abandoned, and we did not need to plan for them because obviously it was clear that those are not the areas of highest risk for us. So what else did the satellite imagery help us do? Mapping vaccination reach. We needed to convince globally, the global community, that we are not just saying we are vaccinating, but we are actually reaching these locations and in multiple times. Because for routine immunization, you need to also visit locations multiple times to deliver services. So what we did was, with the satellite imagery and the vaccination tracking system, we're able to show locations we're able to go to and where we're not able to go. Now, so we assessed a number of settlements. Over 12,000 settlements were assessed. Over 7,000 were fully inhabited, and 779 were partially abandoned, and then 3,000 were abandoned. So this helped us to plan for our activity. So what did we do? This is part of the achievements. We conducted a number of rounds of reaching every settlement, and over 22 rounds. And this is the number of children vaccinated, the settlement visited, and where we were able to reach. All these activities were tracked using a vaccination tracking system, just to ensure that whatever we say is backed with information. This is for the reaching inaccessible children. This also we're able to do to be able to take vaccines. Mapping and vaccination reach in conflict setting, very important. Where there's no mapping, and what that means is that you must be able to demonstrate where you started from, show what you are doing and what you are achieving. These maps show what we have been able to do. One of the things we did was also to estimate the number of children that were trapped. And this slide shows these children were the children that we were suspecting could be harboring the virus, and they will sustain the transmission. And that way, we're able to continuously reach them and monitor them over the years, and that gave us the confidence to be certified. Routine immunization also improved within this period. This mixed NIC survey that shows the 2016 and 2021 showing some level of progress in the conflict setting in terms of delivering routine immunization services. Now, this is a summary slide showing the strategies we deployed. These are, some of them are non-conventional, non-traditional strategies that we deployed to be able to deliver vaccines to areas that were affected with insurgency. Now, this is also for routine immunization and other PSC services. Integration became a key thing that we needed to do to integrate all services. Currently, these services are being provided in the state extended outreaches to reach zero-dose children, hard to reach outreaches, special outreaches, optimized outreach sessions are being conducted across the state based on the security situation to deliver services. This is also a summary slide just showing the progression from when we started and to where we are today. Now, my best practices that I think we should pay attention to is that security assessment and continuous review of this security assessment is key. If in conflict setting, if you cannot review what is going on, then likely you will not be able to have approaches to deliver services. Flexibility to innovate and strategize at the subnational level. So we do not depend on someone from outside the state to tell us what to do. We brainstormed and came up with our strategies, and we delivered services, and Borno was certified polio-free. Continuous funding by partners, very important, and government. EOC coordination with partners. So we had this incident management system where all of us sit together. No partner worked outside the EOC, and every services that were being delivered was discussed and criticized and critiqued, and then information was sharpened, and then services were delivered. Intensive use of satellite imagery, I will not overemphasize that, very important. Where there's massive displacement, satellite imageries are very useful. Coordinating vaccination with humanitarian actors, where food is being delivered, where services are being delivered, we work together with those teams to deliver vaccines. Flexible age group, flexible age schedule for measles and polio vaccines and other vaccines. This is still ongoing in the state. Use of locals to deliver vaccines, very important. Every conflict setting, you will find someone who could do something that you never thought will happen. Engaging security forces, use of Indigo. Indigo is a vaccine carrier that you could take to the field, and it will stay for up to 5 days, keeping your vaccines in good cold chain, and you'll be able to deliver your services without worrying to go and come back to the security compromised areas. Because one of the biggest challenges in conflict setting is movement between the health facility and the community and the locations where services need to be delivered. In conclusion, one of the things that we have learned, and I want to just blow this and really emphasize it, never say never. No one ever thought the military will help to deliver vaccines. There is something you can always do. We never knew that we'll be able to estimate the number of children that are still trapped, but it did happen. This came out as a result of never saying there's nothing to do. So nothing is impossible, anything can happen and can be done. Interruption of wild polio virus type 1 in conflict areas of Borno using unconventional approaches to deliver vaccines also testify to this. These approaches can be used and can be adopted for identifying and reducing zero-dose children anywhere where there is conflict. We can reduce the zero-dose children across Nigeria by innovation, flexibility, as demonstrated in Borno State Polio Program. Use of vaccination tracking system as evidence to show vaccination reach in conflict areas builds confidence and shows progress with vaccination. These are some published materials that you can always look at. All these presentations most of them came from these experiences that we had. And this is to acknowledge Borno State Primary Healthcare Board, the Ministry of Health, Gavi, US CDC, AFINET. All this was a teamwork, and UNICEF, WHO, CHAN, IRC, Rotary International, BMGF, and Solina. Thank you, and over from me.
Thank you, Dr. Melton, for that insightful presentation. Thank you very much. Borno State indeed is a testing field, it seems. After these enlightening presentations, it's your turn to contribute. We value your first-hand knowledge in shaping effective approaches to reaching zero-dose children in diverse settings. So this is a time where we deliberate, discuss, share our experiences, our field experiences, whether you're in urban areas, remote communities, or conflict zones. Your experiences and strategies are vital. So please take this opportunity to share in the Q&A section or raise your virtual hands to speak. Your insights will definitely enrich our discussions and help us to ensure that every child receives life-saving immunization. With that said, I have a couple of questions here for both presenters. I'll start with Dr. Muknan. The first question for you is, did you consider including CSOs in these strategies, like during microplanning, community mapping, and SBCC at community level, as they know the communities and community stakeholders very well? So did you consider including CSOs, Dr. Muknan?
Yeah, so thank you very much. Thank you for asking that question. Yes, in our micro planning and the strategies we deploy to different communities, we encourage our state team members to engage with CSOs. Now, I would like you to understand that what we did at the state level and at the implementation level is the fact that the micro planning are not just done by officers that come into those communities. We engage with the committee members and we deploy strategies. We deploy strategies with the CSOs and committee members in those communities to ensure that the information gets to the right people, we enumerate the right population, and we have continued to do that. In Sokoto State, for example, we're working very closely with GISCO, with Assa Tahir Foundation, who have a very good understanding of the different community members. In Plateau State, we have organizations like CAPS, who provide leverage and access to those communities. We leverage the network of some of our partners, MESH, Chigari Foundation, to engage the communities and stakeholders. And yes, indeed, the CSOs understand those communities. But just to remind us that those are not typical communities that are stable. Those are communities that are in conflict that we go to. So sometimes we leverage on community members that have high risk appetite, that are willing to go to those communities and to engage with these people to get us the numbers and identify communities. And as we do that, like I said earlier, identification is a reiterative process. There are certain communities that we didn't even know existed when we did the first round of the DEX review and the micro planning. But because of the engagement with the local community networks, like in Borno State, we have Herwa and all the likes, we're able to identify new communities, identify some IDP camps in Sokoto State that help us to reach those, the fragile or conflict settings in those places. So yes, CSOs play a very key role and we continue to identify them. And we have bigger strategies in the next phase of our implementation to have engagement meetings with them to discuss the successes, the challenges, to enhance our access negotiations in those communities. Thank you and over.
Thank you, Dr. Nche, for your response. The next question I have here is for Dr. Melton, and it goes thus: has your engagement or relationship with the military affected your services in any location, particularly areas under control of non-state armed groups like Boko Haram or ISWAP, seeing as the military isn't neutral and working in humanitarian contexts requires neutrality?
So thank you so much. You need to view conflict setting holistically. One of the things is that we started with reaching every settlement using local vigilante to go to some low security threat areas, and then we began to use the military when the opportunity came to work with them. However, there were some locations where the military could not go, and then the community informants came in. So it was definitely the military is not neutral. Also, the insurgents are also not neutral. And as much as possible, what we did was to tailor each strategy to be able to meet every challenge. So there were locations where these community informants in inaccessible were able to access, and the military will not be able to go to those places because that will require extra effort in terms of equipment and things like that. So the most important thing is to deploy strategies based on the challenge you have and based on the situation on ground, and then let it be holistic. Thank you.
Thank you, Dr. Melton. I see that we have some other attendees that would like to speak. Ms. Laurel Lar, please go ahead. Ms. Laurel, can you hear us?
Yeah, sorry, I was trying to unmute myself. So good day, everyone. Thank you very much to the presenters. It was really great to see the participatory approach in both presentations, and especially that Dr. Inshe mentioned, integration with other service providers. I think this is great because it makes our work more cost-effective and efficient. Now, please let me just give a little context to myself so that my questions don't sound a bit out of it, but I wear several caps. So as a doctor, an academic, and a researcher in the field, my questions might seem a bit different. So I have had experience in research where we conducted the participatory action research cycle, where we synthesized evidence, like most of you mentioned. We had action planning, we rolled out, we evaluated, validated, and disseminated in various forms like policy briefs, publications, etc. So now my first question to Dr. Inshe, please, can you add more context to what you mean by documents that you reviewed? Then secondly, I know you mentioned, because of want of time, you might not have delved too much into this, but did you have the time and the capacity to have conducted a baseline exploratory research to maybe inform your strategy despite your very good and explicit community engagement strategy that you mentioned? Then I was also glad that Dr. Melton added a slide on lessons learned, because my question was, all seemed good in the end. I know Dr. Inshe mentioned challenges and Dr. Melton, the lessons learned. But I have one question. Considering Nigeria especially and our sociocultural norms engraved in most of what we do, what would you have done differently in all your presentations? Was it all rosy? What were those things that you can tell me if I am a researcher that wants to replicate similar? What are some of those things, pitfalls, that you would advise I avoid? And please, lastly, sorry I'm taking so much time, but it's just because of the passion that I have for this. Can you tell me a little bit about your security challenges and what you did? For example, when I was on the field at a point in time, I had to do a lone research. Despite engaging with the gatekeepers, the community members, I had other telephone numbers. I had the DPO's number, some DSS. As I was driving, I was calling. Can you shed more light on that? Thank you so much, and for the wonderful work that all of you are doing around the world. Thank you.
Thank you, Dr. Love, for that detailed contribution, comments, and questions. We'd like to take some more questions and comments from our participants. We have up next, in the chat, we have some questions. We still have some more people raising their hands.
Economic factors such as opportunity costs and teachings of zero dose and transportation.
Yusuf, your contribution, please. Mr. Ahmed Yusuf, your contribution, please. Your volume is very low. Please, can you check the audio on your device? Mr. Ahmed Yusuf, can you hear me?
Yes, I can. Am I audible now?
Yes, sir, loud and clear. Please go ahead.
Okay. Thank you very much. Good afternoon, colleagues. Thank you very much, Drs. Melton and Inshe, for your beautiful presentation. Mine is a comment that is going to eventually culminate in a question. I was lucky enough, or should I was privileged to work in some of those security compromised LGAs here in Sokoto. Sorry, my name is Ahmed Yusuf. I am a NSTOP consultant here in Sokoto. So in 2021, I worked in one of those security compromised LGAs, Gudu to be specific, and we had a scenario where we had access to a gatekeeper. We were discussing with the gatekeeper, and at some point, he actually made effort to allow us to use local vaccinators to reach them, reach children with RI antigens. However, along the way, we had a little bit of a problem, should I say, or a challenge, and the plans changed. And one of the leaders of the bandits at the time suggested that there are two health workers they trusted and believed would not leak whatever secrets they have from the community out. So they suggested that if we must vaccinate children in those settlements, we have to use those two people. We agreed to this because at the time, the settlement has not been reached for a couple of months with neither RI antigens or the oral polio vaccines. And then eventually we had to agree to that concept. Sorry, I'm taking so much time. We had to agree to that concept, and then we gave these two vaccinators, or should I say these two health workers, vaccines, and children in those settlements were vaccinated. This happened for about 2 months consecutively. So at the end of the day, when the security personnel in the LGA, that's the military, got wind of this, they interpreted it to be that these two persons were more or less like informants to them. Otherwise, why would they say they trust such people to actually carry out such an activity instead of allowing locals in the community to do that? We tried to persuade them through our communications with the gatekeeper. We tried to make them understand that this was just a health-based issue. We were trying to address these issues of non-vaccination in those communities. Now I'm in a different LGA with also security compromise. Luckily, it's also part of the LGA selected by the Gavi Zero Dose Learning Hub as LGAs where a lot of zero dose children have been identified. And we are beginning to see a trend in this, a similar trend in some of the settlements we have. We've tried to reach a couple of settlements and we are told that they've been overtaken by bandits and they are in charge of what happens or who goes in and who comes out. And communications like this have been coming up. So the question now is there anything that, if it has something like this happened in Borno, or is there anything that our speakers can say to help assist us do things differently so that we don't have a repeat of what happened in Gudu LGA some years ago? Because it started well and then it ended badly. So there's no end point to the situation for us in a situation whereby we get to continue to vaccinate children in those settlements until probably they are fully immunized before we now say that we have achieved what we want to do there. Sorry I took so much time. I needed to give a background to what I was saying. Thank you.
Thank you, Mr. Ahmed Yusuf. We have some more participants here that would like to speak. I request you to please keep your contributions and questions as brief as possible so we can delve into deeper discussions. Mr. Ishaku Abdullahi, please. Kindly unmute yourself and make your contributions. Mr. Ishaku Abdullahi, can you hear me?
Yes. Hello.
Audio is a bit choppy, sir. Good afternoon. We can hear you better now. Yes, we can.
First and foremost, I would like to commend the presenters.
Sorry, it's still a bit choppy, sir. Mr. Ishaku. So you may feel free to type your questions in the Q&A section since your network
Hello,
causing you to sound very choppy. And probably network. Yes, go ahead, sir. It sounds better.
Okay, thank you very much. My question goes to the second speaker, that's Dr. Melton. He started his presentation by admitting some of the challenges he had in the security compromised areas in the course of giving vaccines and what have you. So my question is that how has he been able to overcome things? And the second is that he mentioned that he was able to engage locals to be able to vaccinate children in security compromised areas. So I don't know if those people are not as in case of handling vaccines and what have you. So I don't know what strategy is going to achieve that. Thank you very much.
Mr. Ishaku, I'd like you to please type your question in the Q&A as well. Towards the end, it was a bit choppy and we couldn't get the last part of the question. Will it be possible for you to please post it in the Q&A? Thank you. Next, we have Mr. Lawal Sani Mohammed. We are muting you for you to speak and contribute, please. Go ahead. Mr. Lawal Sani, can you hear me?
Thank you, Margaret. Mine is more of a question, and I have already typed it on the Q&A and to Dr. Mugnan. Thank you.
Thank you, Mr. Lawal. Up next, we have Mr. Usman Mohammed. We are unmuting you for you to speak and contribute, please. Mr. Usman Mohammed, can you hear me?
Hello. Are you hearing me, Margaret?
Loud and clear, sir. Please go ahead.
Okay. Thank you so much. My own a question goes to the first speaker. He mentioned some nutrition services. They integrated it with immunization activities. So first of all, my question, I want to know the type of nutrition services they offered and what type of commodities or services they are rendering to the children. And I want to know the strategies they use to integrate such kind of services with immunization services, because it's not every child that are entitled for the immunization are entitled for the nutrition services. So I want him to share more light about such kind of services and the immunization, please. Thank you so much.
Thank you, sir. Up next, we have Mr. Musa Bello. You've been allowed to speak, please. Your contribution.
Hello, good evening, Margaret. Two of us are here, myself and Dr. Tukur. I'm the focal person for AHBN from Kano. My question is to Dr. Musa Melton concerning the security compromised areas. Have they encountered any hesitancy or rejection among the communities, and what are their strategy for addressing that? I have Dr. Tukur with me that also have a question. Thank you.
Thank you, Margaret. Mine is more of a comment than the question. Given what Dr. Melton highlighted as challenges for taking vaccine to trap communities, why have we not considered using unmanned aerial vehicles, that's drones, since it has been successfully used in other places to deliver drugs to hard-to-reach areas? I think that can cut on most of these logistical challenges. Thank you, and over.
Thank you, over.
Thank you. Thank you very much, sirs. Your questions have been noted. Up next, we have Mr. Maman Aliyu for your questions, please, and your contributions. Your contributions.
Hello, can you hear me?
Yes, we can hear you loud and clear, sir. Please go ahead.
Okay, thank you very much. It's an afterthought because somebody just mentioned what's actually in my mind. I listened keenly on the two presenters. The approach is still virtually the same for each one of them, using a human interface as far between the threats and also the output. So I also wanted to say that in places like Indonesia and other countries, drones have been deployed instead of this local approach of, but you have to do with what you have. So maybe that is it. I wanted to say, since we have GIS, we can also have the military. Why don't we add drones, to delivering of the vaccines to the zero-dose communities? Thank you.
Thank you, sir. We'll take some more questions. We have Dr. Hassan Musa. Please, sir, go ahead with your contribution. Thank you.
Good afternoon. Thank you, Margaret. Thank you, Dr. Melton and Dr. David Nahi. I want to quickly comment about the hit and run strategy that has been deployed in some parts of Plateau and Sokoto, vis-a-vis looking at team deployment and having a correct blend of mobile and fixed teams in the perhaps an identified area that will be targeted for the hit and run strategy. It is all known that community engagement and intensified SASM activity is required to mobilize for routine immunization and perhaps reaching out to zero-dose communities. How do you ensure that you precisely deploy the team to go and hit, vaccinate, run, vis-a-vis ensuring whether you are to deploy a mobile team and perhaps what is the deployment plan vis-a-vis the realities on ground? I work as a consultant to African Health Budget Network in Bauchi State, where we are supporting HBN is supporting zero-dose learning hub implementation. Thank you.
Musa, for your contribution and your question. It will be answered shortly. Up next, we have Dr. Charles Akataobi. Dr. Charles, your contribution, please.
Yeah, thank you very much, Margaret. And thank you, Dr. Nshe and Dr. Melton, for the great presentation and the great work to reach zero-dose children. So my questions primarily is, how do we ensure that the numbers that are generated from these people we deploy to some of these places where supervision cannot reach are truly vaccines getting into the arms or mouth of children? We do know that even in places where there are no security issues, conventionally, we've seen people throw away vaccines, whether injectables or oral polio vaccines. And many times we find this out through supportive supervision. So how do we guarantee that the numbers reported as vaccinated children actually are truly vaccinated children? That's one. And then Dr. Melton specifically, I see most of these strategies worked effectively for the polio because it's oral. Did we also use the military for routine immunization? If not, what strategies are used specifically to target routine immunization outreach? Thank you, and over.
Thank you very much, Dr. Charles. And with that, we're going to close the comments and contributions section right now and allow the speakers, the presenters, to give us insights on the questions they have received so far. So we'll start with Dr. Muknan Nshe. So I'm sure you have your questions and contributions, your responses ready to the questions that were asked. Whenever you're ready, you can take the stage, please. Thank you.
All right, thank you very much, Margaret. Can you confirm that you can hear me loud and clear?
Yes, sir, we can. Go ahead, please.
All right, thank you very much. The questions and comments are a demonstration that the participants have followed our presentation and they do share the wealth of their experience in the things we are doing. I would like to start with the last question that was asked by Dr. Charles, and then I'll go into the other questions that I've been able to pen down. So thank you very much, Dr. Charles. I would like to say that when it comes to data validation, to make sure that the numbers that are generated are actually vaccines in arms and not necessarily just people pouring out vaccine and wasting them, the few things we have enshrined into our teams have helped us to track and validate the numbers that we present. The first of it is the fact that as a program monitoring tool, we deploy what we call the ComCare app, which helps us to validate every child and monitor longitudinally every child that we have said to have vaccinated. And that helps us to first capture coordinates, number two, get the information from the child, and then be able to track that into the register that is uploaded on the DHIS2 platform. The second thing we have tried to do is the issue around staff motivation. Whereas the routine activities include paying staff a certain amount of stipend, we make sure that at the point of orientation and onboarding of the staff, they understand the importance of the vaccination they are going out to conduct. And that way, we are able to make them see that we are here because of the challenges in previous times. And so once we get those kind of staff that are well motivated to go into those communities and to vaccinate properly, we pay them what the kind of transport allowance that is the estimate that can take them to and fro. Most of the times, the challenges around vaccination and vaccination teams are such that sometimes what is paid as remuneration or allowances for vaccination are inadequate. So a lot of the vaccination team play some pranks around with vaccines. The third thing we do is to balance between targets and daily implementation plans. As much as we want to cover large numbers of people, we understand that the humanitarian areas, the fragile and conflict settings are not easily accessible compared to other settings. So we ensure that the staff understand the importance and they are able to set realistic targets that we review before they go in to vaccinate, so that someone will not come back and tell you he has been able to vaccinate 1,000 children in a place that you know, because of the mapping that has been done, because of the enumeration and the assessment that has been done, that number cannot be generated because of the level of displacement. So those are some of the things that we have been able to do, including capacity building and all of that. Those are some methodology to reduce the tendency to give fake data or to give wrong data. I would like to also just quickly respond to the question around integration with nutrition services. So for the places where we've integrated nutrition services, mostly in some communities in Borno State, is that we work very closely with the field teams of Save the Children that provide outpatient therapeutic centers. They operate outpatient therapeutic centers in some of the communities that we have to overlap. And in those communities, the field teams work in close coordination with the Race for Sahel teams to provide nutrition services that are ready to use therapeutic feed in those communities. So those, what we are providing are not raw food. They are not some high kind of commodities, but they are ready to use therapeutic food that are for children in those communities. So we plan the sessions in conjunction with them and in coordination with their teams to provide services in those communities. I had a question from Professor Lar, who happens to be my teacher. So in terms of the documents reviewed, the time we had allotted, 20 minutes, is probably inadequate to, discuss in detail all the strategies involved in the processes from the inception phase to the planning to deployment of strategy. But the documents we reviewed are the Mixed Needs Survey, the NCIPS document, other publications that are around the vaccination conducted in fragile and conflict settings, in Nigeria and outside Nigeria, some of which Dr. Melton referenced, because some of the interventions were things that had taken place before the implementation proper that we started. We also leveraged the Institute for Health Metrics and Evaluation publication to look at the data. And we also ended up by having some engagements with partners that have robust experiences, in the immunization space, so that we can tailor strategies and not repeat some of the mistakes that have been made in the past. In terms of the baseline for the communities, as much as we recognize that certain communities are very difficult to access, what we did was that we sampled some of the communities and we conducted a rapid assessment, or what we call the quick informal assessment, which was a mixed method participatory approach with both qualitative and quantitative data, where we discuss with the communities and they were able to identify the communities, discuss and tell us the sociocultural challenges, the demand side and the supply side barriers that have affected, access to the vaccination and reach of children in those communities. So those formed the basis for the engagement. Because of time, I'll just leave that. And I'm sure that at some point our emails will be shared and we'll continue to share some of our learnings. Thank you very much, and over.
Thank you very much, Dr. Nshe. Thank you for responding to all those questions in such short time. Dr. Melton, you're up next for your responses, please.
So thank you so much, Margaret, for giving me the opportunity. I will move a little bit fast so that I address as many questions that I could. Graded population disparity between what the satellite imagery says and what we found on ground, yes, because there were some settlements that had indication that they were habited, there were people living there, we get there, the military get there, or the community informants get there who helps to vaccinate, and then they report back that these places did not have populations in there. So we had those things and we're able to document those false positives like that. Then what will we have done different on ground? One of the major challenge with conflict is that people always stick to saying there's nothing we can do. This insecurity situation is so what I will do differently is to quickly move away from the conventional methods of service delivery. I'll move quickly to innovate. I'll move quickly to think outside the box, and I will move quickly to engage even unconventional methods to deliver my services. And I can tell you, with surveillance, looking for FB cases and looking for outbreaks in those locations, people who go to bring firewood, people who go to conduct certain businesses in those locations were able to help us. Is there any hesitancy in the conflict areas? Yes, there's hesitancy. The biggest challenge is no one in conflict usually will ask for vaccines. The first thing they will ask for is shelter. They will ask for food, and then they will ask for other food. So one of the things you quickly do is to make sure you tag along with humanitarian actors that provide food, shelter, and other services. That way they'll be able to understand the difference between the immunization service you are delivering and they will accept. But I can tell you from experience, they really will reject vaccines. Last 2 weeks, I was in Mongono. You'll be surprised when children line up to take measles vaccines as if it wasn't an injectable. The use of drones. Well, we consider the use of drones, and again, we're not too familiar with it. I know that it will work. However, we had an alternative of United Nations Health Air Services helicopters that fly our commodities to a particular locations where these vaccines are picked up from, particularly in a safe area closest to the location where services will be delivered. But Borno State considered the use of drones to deliver services, partly maybe issues that are beyond my knowledge stopped that from being done. Then the cost of engaging the military and vigilante. The military are not, you don't consider their cost because they are being taken care of by the government of Nigeria. It is a patriotic contribution to the immunization system to deliver services on behalf of the country. And so for the local vigilante, you will we have some information about what we usually use to engage them in terms of resources and money that was used, and we had funding for that. Monitoring service delivery in areas where supervision cannot be conducted. One of the big things that we used to prove that services were at least delivered is a vaccination geo point showing a visit to a particular location. Because the truth is that it is common that just like I said, we had 2 years of no wild polio virus, and then suddenly we had these 4 cases coming from certain locations. So the viruses or the diseases, the vaccine preventable diseases, will not pretend that they are not there, so they will show up. So one of the things we did is vaccination tracking system, which shows the movement from the point of departure to the point of service delivery and back. However, there are other ways, scientific ways, where we can check whether these vaccines are delivered or not. The use of military to deliver routine immunization. Yes, in some locations we had, like during campaigns where we needed to deliver measles vaccines, yellow fever vaccines, the military medical corps supported to deliver those vaccines in those locations. And for now, I think, then the issue of neutrality, of course, like I said, you deploy all strategies based on the situation on the ground. In the conflict in Borno, the military had areas they were in charge of or covered, and then the insurgents had some areas. So there was this clear demarcation between where the insurgents were and where the military were, and where the military were conducting operations. So the military helped to conduct operations and then provide services, while the community informant, which I want to emphasize as my last point, to say that the community informants, locals, are a huge way of delivering services in conflict settings that everyone should consider. Thank you, and over.
Thank you very much, Dr. Melton. Before we conclude today's session, I would like to invite Dr. Yahya Mohammed, the project coordinator for the Zero Dose Learning Hub Nigeria project, to share some closing remarks with us. His leadership and insights have been instrumental in guiding this project. We'll be honored to hear your thoughts as we wrap up today's discussions. Over to you, Dr. Yahya.
Yeah, thank you, Margaret, and good afternoon, good morning, good evening, colleagues from all over the world. Thank you for participating in this webinar, the first ever webinar series, where we have over around 250 participants at different times, at the peak of time. On behalf of the organizing committee, I would like to extend our heartfelt appreciation for those of you that have been able to join us at this inaugural session. I want to specifically extend my regards to our speakers for generously accepting to share their expertise and insight with us. Dr. Muknan from Race for Sahel and Dr. Melton from Affinet. We greatly appreciate your participation. I also want to extend my regards to each and every one of you that attended this webinar. Your participation and engagement were integral to our success. I want to specifically recognize the role played by Gavi for the technical and financial support to the implementation of this webinar series, specifically Dr. Hedy Reynolds, who coordinates these global learning hubs. JSI, I saw Erin, who is the global lead, our global partner, has been with us throughout this session. My appreciation to the JSI-led consortium and also to our colleagues at AHBM, and to all of you that have been able to stay behind. Please watch out for subsequent series of lectures that will address issues around how to better identify and reach zero dose in Nigeria. Thank you.
Thank you, Dr. Yahya, for that closing remark. And thank you everyone for your active participation and insightful contribution throughout today's Zero Dose Learning Hub webinar, the first ever. Your dedication to the cause of immunization is truly commendable. Before we conclude, a quick poll will pop up on your screens. I encourage you to take a moment to participate. Your feedback is invaluable as we strive to improve and tailor future webinars to your needs. Once again, thank you for your participation. I'd like to commend and express gratitude to our speakers for sharing their expertise and to all attendees for their engagement and commitment. Together, we can make a difference in ensuring that no child is left behind in immunization efforts. We'll be sending you emails, we'll be sending you the recording of the webinar. Let's continue this dialogue together. We'll keep in touch and network and connect, and still, as Dr. Yahya said, delve into deeper discussions on how we can identify and reach zero-dose children till we reach the last child. Thank you and have a wonderful day. Please take a moment to answer the polls. We'll send you a feedback survey as well via emails. All resources will be duly shared with you. Thank you and have a wonderful day. Our time, participation, attention, of